Great. Okay, I think we're getting started here. So here I'm just going to change the view a bit here. I think meeting controls. Great. Okay, I think we're about ready to go. Okay, so welcome everyone to the next MR group seminar. So we have the pleasure of hearing from Dr. James Stewart. So James Stewart graduated with a PhD from the Institute of Biomaterials and Biomedical Engineering at the University of Toronto in 2018. And his thesis focused on improving the accuracy and dosimetric heterogeneity of preclinical irradiation studies. And so he's worked as a programmer and researcher since then in the Department of Medical Physics at Sunnybrook Odette. And he's focused on MR-guided CNS radiotherapy. So he was previously employed in a research capacity at Princess Margaret Cancer Centre, exploring adaptive radiotherapy strategies. And with that, maybe I will pass it over to James to take it away.
Thanks for the kind introduction, Liam, and the invitation to speak here today. It's rare that I get to be called Dr. Stewart ever. Usually my friends are setting me up for a joke after I've done something clumsy, so sort of funny to hear. But again, thanks for the invitation, and I'm happy to spend a few slides talking about how MRI is changing radiotherapy treatments for glioblastoma, mainly here, but also in centers across the world. And one slide on the, yeah, and so one slide on the incidence of this tumor. It's the highest grade of glioma, and it has an incidence of about 3 or 4 people per 100,000 people per year. So that translated out to the population of Canada, that's about 13 to 1,500 new glioblastoma diagnoses in Canada each year. Approximately 150 to 200 of those will be treated at Sunnybrook Hospital. And despite its relatively low incidence as a cancer, it's a devastating diagnosis by any stretch of the imagination. And there hasn't been a lot of advance in terms of treatment, especially treatments that have been shown to progress to change the survival of this tumor in about 20 years. So this is the last trial, again, arguably to do so. This is the STEP trial from about 20 years ago. And it was looking at the combination of radiotherapy plus temozolomide chemotherapy versus radiotherapy alone across about 550 patients. And all these patients were treated with surgery beforehand to the maximum extent possible. And again, this is the last robustly shown trial to improve survival in this patient cohort. And this information was later updated in about 5 years later, I think 2008 or 2009. And the 5-year survival rate was about 10% for the radiotherapy plus chemotherapy group, and even lower, obviously, in the radiotherapy group, 1 or 2%. So, and that's where the standard of care is today. So if you're newly diagnosed with glioblastoma today, you'll likely have surgery to the maximum extent possible, and then followed by radiotherapy plus this oral chemotherapy at the same time. Once radiotherapy is complete, you continue on that chemotherapy. And predominantly 90+% of these patients progress centrally and go on to die in a few years. But there's been a lot of advances in radiotherapy just over the years coming to today, and we're progressing radiotherapy techniques to try to improve outcomes a little bit for this patient cohort. And I realize not everybody in this group might be familiar with some of the radiotherapy basics. So I'm going to introduce some of these basics as we go along, and I hopefully present a little bit of a history of radiotherapy as applied to glioblastoma. So patients with radiotherapy, they would be treated with a linear accelerator. So this device up here, Sunnybrook has 13 of these linear accelerators, and they deliver a high energy X-rays to the tumor. And the goal for external beam radiotherapy is to target the tumor specifically and then avoid healthy tissue surrounding the tumor. And there are various degrees of freedom with which one of these machines can target that radiation. So this collimator head can move and rotate and then angle around the patient. And so you can see a thermoplastic mask here. So for glioblastoma, the patient would be placed on the couch and under one of these custom masks. But the main method by which one of these linear accelerators are called achieves the modulation of the dose is with a device called a multi-leaf collimator in the head of the treatment machine. So the high energy X-rays are shaped by this multi-leaf collimator. And you can imagine with all these degrees of freedom, you can start to carve away dose in a three-dimensional sense. So with a beam angle from this angle, a little bit of this angle with a particular multi-leaf collimator shape, and another angle with another multi-leaf collimator shape, you can start to add up dose in 3D and create really conformal to the tumor dose distributions. But in radiotherapy, we're typically concerned about the inverse problem. So given this three-dimensional dose distribution that we want to deliver, we want to figure out beam angles and multi-leaf collimator shapes to deliver that dose distribution. And a couple more slides on radiotherapy basics. Generally, we're targeting with radiation, or we want to target with radiation, some well-defined volumes. And by well-defined volumes, I mean these were defined probably in the early 70s by the ICRU, the International Commission on Radiological Units, if I remember that correctly. And so the first is the gross tumor volume, or GTV. It's the visible tumor. So something you can see on an MR, or in some very rare cases, palpate. You can see it on a glioblastoma patient, on a T1 plus gadolinium contrast agent MR. And then this GTV is expanded to something called the clinical target volume. And there's a little bit of art and controversy in defining this clinical target volume. And so nominally it includes the GTV and any microscopic or non-visible spread. And there's some debate, especially when it comes to glioblastoma, about what exactly should be included in the CTV. And we'll discuss that a little bit later. And finally, there's some uncertainties in the radiotherapy process. You can't target the CTV perfectly every time the patient comes in for a treatment. So an additional margin is placed around the CTV to accommodate some of these motions and localization errors. So the patient comes in for a treatment, they're not exactly at the same spot, so there's an expansion of the CTV, and that's called the PTV. And this patient was actually treated about 3 or 4 years ago at Sunnybrook. And you can see with the tools and some of the optimization software that the department has, we've sculpted this nice dose distribution to the PTV while avoiding some of the surrounding OARs. So there's a brainstem in the middle here, of course, and the optic nerves. We've carved some of this color wash dose distribution away from some of these structures we'd like to avoid, but we've still targeted that radiation right around the PTV and the CTV. And this plan delivers a 60 gray, it's called, dosed, and then this 60 gray dose is delivered over the course of 30 fractions. And if you're not familiar with this unit of gray, it's a unit of absorbed dose. And it's defined as I think the amount of radiation absorbed, the energy released by radiation per kilogram of tissue. So its units are joules per kilogram of tissue. And it's not actually a lot of absolute energy that we're delivering to this tumor. If you put all this energy into heating up a cup of coffee, for example, all the 60 gray, and convert it into an energy that can heat up coffee, it would only raise the temperature of a coffee by about 100th or a couple hundredths of a degree, excuse me. But this energy is delivered as ionizing radiation. So it spends its energy ionizing matter, flicking off electrons, and those electrons go on to damage the DNA of both the tumor and healthy cells surrounding the tissue or the tumor. But the healthy cells generally have a capacity to heal themselves a little bit when compared to the tumor. And so we exploit this differential to try to control the tumor while at the same time minimizing dose to the parenchyma surrounding the tumor. And it's easy to ask, especially in hindsight, why do we settle on 60 gray? Why was this CTV definition adopted? Why don't we go to this definition? Why is this something we want to target? Why not something bigger? Why not something smaller? And so I just want to spend a few slides just on a historical, some history of how we got here. So why even do we do radiotherapy? What's the evidence that radiotherapy actually helps this patient cohort? And it was led by pioneering studies in the 70s. And this study summarizes the results over the course of a few different trials. And right away in the introduction of this 1979 paper, they say, radiotherapy has been used to treat intracranial neoplasms for over 4 decades. So that brings it about to the 1930s, according to these authors, when they started to treat brain lesions with radiation. So X-rays were discovered in 1895. So within 30 years of discovering X-rays, they decided, hey, we should, see what happens if we shoot some of these X-rays at a brain cancer patient. But in summary for this paper, they looked at the radiation dose, and this uses an older unit of radiation called a rad. And so 100 rads is about 1 gray. So this is like a 50 gray dose, roughly speaking. This is a 55 gray dose and a 60 gray dose. And I looked at a few patient cohorts. A patient cohort that received no radiation, patient cohort that received less than 45 gray or 4,500 rads, and then 50 gray, 55 gray, and 60 gray, and looked at the median survival in weeks. And you can clearly see, especially with the 25th and 75th percentiles drawn on the figure, which must have taken some time to draw in the 1970s. It gives me newfound appreciation for MATLAB and all the nice figure tools we have today. But you can see, especially the patients treated with a lower dose, and these were likely poor performing patients to begin with, but patients that didn't receive radiotherapy received a low dose radiotherapy. Their survival was measured at about 20 weeks or so. So 4 months or so, 4 or 5 months. And you can see starting at 50 gray, or as we go above 45 gray, you can see we do get a dose response here, and it's going up, at least for the median patient, and of course the 75th percentile and the 25th percentile for these patients. And so this is good evidence and summarizes the studies of the 1970s as well, that, hey, radiation does help these patients, and it's a useful thing to do for these patients. And it's not lost on any of us here that this curve is going up. There's no peak in this curve yet, right? And the authors note this, of course, as well. One could anticipate that a further increase in survival might be achieved by further increases in dosage, right? So can we give more dose and this curve keeps on going up? Does it peak at some point? And this was explored starting in the late 1970s and summarized in the early 1980s. And it was looking into delivering, in a post-operative setting, a 60 gray dose to the whole brain, so WBRT, or whole brain radiotherapy, but then giving just a boost to a smaller volume of tumor. So 10 gray or 1,000 rads to the tumor as they defined it at the time. And I'm not sure exactly how they defined it at the time. But in terms of the survival between these two regimes, and they also looked at a couple of chemotherapy regimes, which is why there's 4 lines on our survival curve here. Giving this 10 gray extra boost to the tumor, at least in this cohort, the lines fairly overlap, right? So there's no benefit, at least in this data, that suggests that giving a small boost to the gross tumor gives any survival benefit. And it's natural, sort of looking back with all our fancy technologies, this is 1983, hey, we have these great tools to deliver radiation and image. What about with using some of our more modern tools? Can we get away with delivering a little bit of extra dose to the tumor? And is there any benefit to the patient? And these are questions that are coming to the forefront now. And it turns out we can actually deliver smaller regions of the tumor to a higher dose. And this, it's work that's ongoing. And this is a small study to determine the maximum tolerated dose that we could do so. So I was looking at a standard of care, so a 60 gray dose to the whole tumor, the CTV, the clinical target volume, and then boost to just the enhancing tumor on T1 contrast imaging. And it was designed to determine that max tolerated dose. Eventually, you raise that dose level so high, the risk of grade 3 toxicity starts to increase, and patients end up getting radionecrosis, and that's a very debilitating toxicity, especially with the burden of disease that's recurring as well. So they found that up to about 75 gray for this little boost region, so you could give an extra 15 gray of dose to these patients. There was no radionecrosis up to that 15 up to that 15 extra gray, up to 75 gray. So it's a little bit of evidence that there is some room to work with modern technology, that we can give a little bit of extra dose to a small volume of tumor. There were no overall survival or progression-free survival improvements in the cohorts, but this study was not intended or powered to come to those endpoints. But it's a little bit of signal that we do have a little bit of dose to say play with and maybe deliver to the patient with intelligently. Going back to the 80s for some history. So at the end of the 70s, the trial that I showed a couple of slides ago, it was focused on whole brain radiotherapy. So there was, fair to say, a little bit of debate about what exactly to target for patients with glioblastoma. And at the time, and due to technological limitations and imaging limitations, these patients just received whole brain radiotherapy. And that led to acute toxicities and some late toxicities for longer term survival. And there was an idea that if we could reduce the volume of brain that's being irradiated in the early 1980s, we could get away with reducing some of these toxicities. But a concern was, well, if we start reducing that field, we start just delivering the dose to say half the brain, is that going to impact control of these tumors? And so studies were performed correlating histology, so a histological section on the right here, with cone beam CT at the time. So on the left side is a CT image of a brain lesion circa 1983 or so, or early 1980s. And they started to correlate these imaging, the CT imaging, with pathology sections. And you can see, hopefully in this pathology section, I think left side of the brain here, it's well perfused, but you can still see there's a little bit of graying in this pathology section. And then so they correlated it a little bit with the CT and the imaging that they had at the time. And they thought that we could probably get away. This is like a little bit of information that we can get away with a reduced volume of radiotherapy dose to these tumors. And that was explored in a clinical trial, which was summarized in 1989. And this trial was actually initially started to look at 3 different chemotherapy regimes. But these issues of how much brain to target with radiation came to the forefront that beginning in 1982, they modified this trial. At the beginning of the trial, all the patients received whole brain radiotherapy. But then they modified this trial looking to chemotherapy drugs. They said, this is such a big issue for the community that beginning at this point in the trial, we're going to randomize the patients to either receive whole brain radiotherapy beginning in 1982, or partial whole brain plus a CD. So that's a cone down. So they actually coned down the radiation that was delivered to these patients. So that's why you end up with this unwieldy title for the report. It's a randomized trial of 3 chemotherapy regimes and 2 radiotherapy regimes. So they're just testing. It seems like they're testing everything, but there was a certain logic to their mid and late 80s madness. And when they looked at the difference between the whole brain from 1982, this randomized radiotherapy group, there was no difference in survival between those 2 groups. So evidence that we can reduce the volume of tissue that we're targeting with radiation and not affect survival. And future studies sort of carried this sort of naturally forward into smaller and smaller volumes of tumor that we're targeting. And that's led to the modern day standard of care, which is actually bifurcated a little bit with 2 sort of philosophies, I think would be the best way to call it. There's an American philosophy, which is a 2-phase approach to radiation therapy. And so panels A and B here, it's the same patient, but what the American approach is to target 46 gray to the T2 flare hyperintense region plus a margin. So we have a T2 flare region. We've contoured out all the T2 flare hyperintensity, and then we added a margin to it. I think it's a 1 centimeter margin, and we're targeting that with 46 gray. And it's a big volume, and you can see in this patient in this plane, it's about half the brain. We're giving 46 gray. And then the last 14 gray, they give just to the T1C contrast enhancing lesion plus another margin. So they cone down that approach in a 2-phase approach. And this is in contrast to the European approach, which is a one-phase approach applying 60 gray to the T1C target, so the contrast-enhancing tumor target, plus a margin, and with the margin being about 1.5 to 2 centimeters. And that's the standard of care for radiotherapy these days, depending on whether, of course, you are a patient in America or European. Canadian centers generally follow the European approach. And these plans are delivered, going back a few slides, they're delivered over the course of 30 fractions. So that 60 gray we're delivering to the patient is delivered in 30 individual treatment sessions. And that's so as to reduce the toxicities to the patient. It gives the healthy tissue a little bit of time to heal between each day's treatment, and still deliver the full 60 gray to the tumor after 6 weeks. And our little schematic here to describe the overall process. The patient comes in for 6 weeks of radiotherapy, but before radiotherapy, in a process called planning, they get a CT and a T1 with contrast MR, shown schematically here. And then at each of their 30 fractions, they're imaged with cone beam CT. And so you can, on this linear accelerator here, you can see a flat panel detector here. On the other side is an X-ray tube. And this combination produces a CT-like image, if you're familiar with it, but it's more of a cone of radiation as opposed to a fan of radiation in a standard CT. And you get images that look like this at each fraction. So this patient that was treated a few years ago has cone beam CTs that look like this at all 30 fractions. And you can imagine, of course, in your mind's eye that we're not seeing these changes that might be occurring over the course of this 6-week treatment. And so what these images are used for clinically is to align the bony skull to where we want it to be. So after the patient lies down on the couch and is set up and ready for treatment, an image is taken, a cone beam CT image is taken, and we can see that the skull is not quite aligning with where we want it to be. And then so that couch can actually move, and does move, to align the skull with where we want it to be. But again, if changes are occurring to the gross target, this radiation plan that we've carefully developed at the time of planning may become less and less optimal as time goes on. And that was something that was a little bit unknown a few years ago, just how many changes were occurring over the course of treatment. And this led to work done here at Sunnybrook and headed up by Sten Meyerhog, a radiation oncologist here, beginning in June 2016 and proceeding all the way through to the end of 2021. And this study was designed to look at what sort of changes happen over the course of radiotherapy. And eventually the study acquired almost 250 post-surgery glioblastoma patients. And I'm sure everybody here has heard about, of course, about the MR-Linac. And this study was started and ended prior to the beginning of the MR-Linac treating patients. So these patients were treated exactly the same as I described on the previous slide, but at roughly fractions 10, so fraction 10 of treatment and 20 of treatment, they were imaged with a diagnostic quality MR scanner. So that's the offline part of this. And they're imaged with post-GAD T1, and they were imaged at 4 time points, fractions 0, 10, and 20, so during radiotherapy, and then 1 month after the completion of radiotherapy. And then after patients were excluded, we got to 129 patients across 506 time points. And on each of those time points, Sten diligently contoured out the GTV and the CTV, with the CTV being a 1.5 centimeter expansion of the GTV. And really, Sten undertook a study to learn what sort of changes are happening over the course of radiotherapy. And so this is a movie that describes these changes in one patient. So this is a T1MR from the time of planning, and you can see the target, or the GTV, contoured in white around the enhancing lesion. And if we go forward to the further time points, you can see substantial changes, and probably more surprising than we might have anticipated going into this study. And this slide shows exactly the same patients, exactly the same time point, just in case the movie didn't play too well for the audience here or over Zoom. And you can imagine in your mind's eye, this MR at the time of planning, we've created an intricate radiation plan for this patient at this time point. And then and then we keep on delivering this plan. And then at fraction 10, their tumor looks like this. And then at fraction 20, their tumor looks like this, but we're still delivering the same plan historically over these fractions. So this nice, really optimal radiation therapy plan at the time of planning, it might become a little bit suboptimal at fractions 10, 20. And you can see in this follow-up scan, this patient did not respond well to treatment at all. And we wanted to quantify this in a nice way. And it's a tricky thing to do because these changes, they're easy to sort of qualitatively see in a single patient, but how do you do that for 129 patients across all these time points? And sort of a simple way to do it was something we're calling the migration distance. And something I've mentioned in the previous slides is that radiotherapy process relies a lot on margins. So the CTV is an expansion often of the GTV or the GTV plus a margin. The PTV is a CTV plus a margin. So it relies on this concept of margins a little bit. So we wanted to use a similar sort of concept to describe the deformations that occur in these patients. So say if we have a target or an enhancing lesion at one time point at planning in the gray, and then later it looks like this blue ellipse, we define the migration distance as this maximum distance. And it has a nice tie-in with radiotherapy margin concepts in that if we expand our GTV at fraction 0, our planning GTV, by the migration distance, we completely encompass that change. So it's a simple way to report some of these deformations, but it ties in nicely with radiotherapy margin concepts that the community is familiar with. And we can plot, we found it useful to plot the migration distance along in a scatter plot for all the patients, with the migration distance being plotted along the X, and then the relative tumor volume along the Y. So in this patient that we looked at a couple slides ago, the volume of the red target at fraction 20 is 36.6 cubic centimeters. So compared to planning, it's about 85% or 0.85 of the volume at planning and has a migration distance of about 17 millimeters. And so we can plot it on a scatter plot, more quantitatively on a scatter plot down here, with again, migration distance along the X, the relative volume along the Y. And we found it useful to divide our scatter plots into these 4 quadrants, where we're dividing the Y-axis by a relative volume of 1s. So any points above 1 tell us that the tumor is increasing in size and these patients might not be responding well to treatment. Below 1, there's a responder or maybe some other physiological mechanism happening, like a surgical cavity resolving, for example. And along the X, we're pigeonholing somewhat arbitrarily a migration distance of 5 millimeters. And above 5 millimeters tends to indicate to us that maybe this plan that we've optimized is a little bit suboptimal because we got a little bit of the tumor sort of poking out now. And that could be very detrimental for a radiation therapy plan. And so what this looks like across all the patients and all the time points in the study at fraction 10, 20, and post 1 month is shown in this slide. And each of the time points, I think, tells a similar message. We can count up the number of dots in each of our 4 quadrants, like we discussed. So this lower left quadrant might be considered good responders. Their treatment will still be, the treatment designed at planning would still be generally pretty optimal as these patients progress through treatment. So about half the patients fell into that quadrant, whereas 14% and 20% at fraction 20, these patients, their volume actually decreased of the target, but they had a migration distance greater than 5 millimeters. So that hints at some of the perhaps surprising deformations that occur in this patient cohort. And yeah, and just to emphasize that message, so about half the patients have a migration distance greater than 5 millimeters. So their radiotherapy plan might not be optimal going through treatment. And about 20% of those patients have a migration distance greater than 5 millimeters while also having a decreased target volume during radiotherapy. And we can pigeonhole this data in different ways. So this plot shows the exact same data as the last slide, the exact same scatter points, except now we're pigeonholing patients according to the extent of surgery. So these patients are classified as after surgery as having a biopsy. So these patients weren't really surgically operable, but they did have a biopsy. Some of them have a subtotal resection. In fact, the majority of patients have a subtotal resection. The surgeon wasn't able to get the full extent of the tumor, and finally a gross resection. And so you can see, at least qualitatively, the gross resections, they tend to be closer to our lower left quadrant. So these would be more of the, let's say, good actors in terms of radiotherapy, whereas the subtotal resections and the biopsies might perform worse or might need more frequent monitoring over the course of radiotherapy. And we can do that a little bit quantitatively. So a slide just presenting the same data, but just to emphasize that the results were statistically significant across these three different time points for our different surgical categories. And this data was taken and run with by a clinical fellow here, Dr. Wei Yong, again, under leadership of Dr. Sten Meyerhag, and looked at it in a multivariate analysis. And they were interested in, can we predict, using just some of these easy-ish factors, can we predict which patients are going to progress earlier or which patients are going to survive longer? And they even just looked at simple things like the volume of the tumor at fraction 10. So it's a very early time point compared to what was done historically and what's done for the standard of care. But if you divide patients, and I can't recall exactly how they came up with 1.33, but if you divide patients into two groups, those that the volume of the tumor was 133% or lower at fraction 10 compared to 133% and higher, you can see at this early time point, fraction 10, you can start dividing those two patient groups into longer-term progression-free survivals and shorter terms, even though the absolute numbers are pretty small for this cohort. But it does suggest a quick and relatively easy way to pigeonhole these patients at fraction 10 and find patients that are at risk of progressing early after treatment. And so, as I mentioned, that study was initiated before the installation of the MR-Linac, and I imagine I don't have to talk about the MR-Linac too much in this group, but it's probably right above us, give or take. Yeah, it's on the floor above us, pretty close to where we are right now. And then instead of using a Linac and a cone beam CT, it fuses together a Linac and an MR machine, which is a technological feat and a feat of engineering. Magnets and linear accelerators typically don't want to be together, roughly speaking. And what this allows us is to take daily MRs of these patients as they go through treatment, including real-time imaging in 2 dimensions during the beam on, a whole suite of functional imaging modalities that I won't talk too much about because I don't know much about them, and everybody in this room would eat me up on it. But the benefit, of course, is the endless imaging with no dose, either before, after treatment, and during treatment. So instead of a scheme like this, which I mentioned a few slides back, where we're getting these cone beam CT images every day, we're using this technology to measure the patient's tumor and adapt to it on a weekly basis. And so this was done under the auspices of a phase 2 trial led by Dr. Jay Detsky, a radiation oncologist upstairs. And so instead of getting these cone beam CT images at every fraction, instead weekly, the patient was injected with gadolinium contrast and imaged directly on the MRI. And what this provided is actually measuring, and these are delineated every week for the patient while the patient is on the bed just before being treated, delineated the target each week. And then a brand new plan is created for that week with the patient on the bed and then delivered. So we're incorporating these changes directly into the treatment. And what this allowed in this United trial was, instead of 1.5 or 2 centimeter margins, which are common before the MR-Linac, what this allowed in this trial especially was a 5 millimeter margin. So this distance from the red to the orange contour is an isotropic 5 millimeters. And if you tried to pull off something like that using, let's say, standard Linac technology, based on the deformations that we saw a few slides ago, this would raise concerns about missing the target. So there's so much deformation that you can't use this 5 mm margin unless you're adapting to it or monitoring it on a frequent basis during treatment. And that's still anatomic-based imaging, and we can also acquire functional imaging or in T2 imaging like FLAIR or ADC imaging. And just to show one slide, courtesy of Brian Keller and Angus Lau, can start to monitor some of these FLAIR changes, for example. And so FLAIR is either edema or perhaps microscopic disease. We can start to monitor these changes and see that the FLAIR, for example, in this patient is decreasing throughout the days of treatment. And I just wanted to end on 2 or 3 slides just on functional imaging, especially considering the audience here today. Rachel Chan was kind enough several months ago to pass along this review of functional brain imaging interventions. We're far from the first group to look into this for this refractory cohort. And there was a nice review paper that summarized these studies. So there are 32 studies that looked into different aspects of functional imaging for glioblastoma patients. Some were looking at how to define the target better, so how to define those CTVs and GTV better, all the way through to looking at recurrences. So where do the tumors recur and what are the survival, and across a multitude of PET-based and MRI-based technologies. And I was planning on actually showing a table listing all the studies, but the table in this paper showing all these studies and summarizing them was 4 pages long. So suffice it to say that there's a lot of active interest and research in this area. And I'll highlight a few studies done here, all based on DWI or ADC imaging. And the first is Liam's paper. It just came out less than a month ago at this point, I think. Is that right? Yeah. Yeah, a little over a month ago. Yeah. So, and he was looking at diffusion weighting imaging on the MRI. And what he was particularly interested in is these regions of low ADC within the tumor itself. And so the low ADC regions are highlighted in this paper in this patient anyway, with the blue color wash. And you can see that this low ADC region is actually increasing. Increasing over the course of treatment. And I think the critical contribution to this paper was if we look at something just like the change in the GTV volume, so that's that T1 plus contrast volume over the course of radiotherapy, and just look at it at week 2. If you remember from a few slides back, we showed that you can predict survival a little bit just using that metric. And Liam did a similar sort of analysis in his cohort, and the results sort of confirmed that analysis. But it was more beneficial, Liam found, to look at the change in this low ADC. So if your low ADC is increasing during the course of treatment, you'll tend to have a worse survival compared to when ADC is not increasing. The region of ADC is not increasing so much. So I muddled it a little bit there, but I think I got the message across, Liam. Yeah. And to finish with 2 more studies done here. This was led by neuroradiologist Pejman Marlani. And while Liam was looking inside the GTV, looking at ADC within inside the GTV, Pejman was curious about the region surrounding the GTV. So there's ongoing controversy, and I've shown a few slides ago, about what to include in terms of radiation targeting around the GTV. And so Pejman asked the question, if we look at increments, geographic increments away from the GTV, so in this patient, we have the GTV in red, and we start looking at increments away from that GTV on the ADC map. And so this is a 5 mm ring from the GTV, and then we pool all these ADC voxels within that ring. We can calculate an ADC value for that ring, and the rings are shown in this survival plot, or rather a stat plot on the x-axis. We can look at all those ADC and then asks, what's the survival for correlating the survival of the patients at that ring level, if that makes sense. So for example, using a 5 millimeter ring around the GTV, it's statistically significant for overall survival in these patients at a p-value of about 0.05. And so Petrin found, using this method, it was statistically significant all the way up to about 11 millimeters. And there's some, you could argue that there's some weak evidence here that closer to the GTV, so these values up to about 5 millimeters, might be better predictors of survival in this patients. That might be playing a little bit fast and loose with the stats to come to that conclusion. So it's a weak argument, but it gives a little bit of evidence towards that end. And finally, I'd like to end with an idea that a clinical fellow had, Dr. Daniel Palores. I apologize, Dr. Daniel, because I know I got your last name wrong there. But he was asking a similar sort of question. What regions around the GTV do we want to include and target with radiation? And he was interested in high B-value diffusion-weighted imaging. So if we look at either a set of planning images, MR images, or weekly MR LINAC images from the MR LINAC, if we look at a T1 with contrast image, with the GTV contoured out, and a T2 flare image, so these would be standard images that the radiation oncologists would get. There's this sort of region that's outside the enhancing tumor, but it's hyper intense on the flare. And so Daniel's question often, and it's a question that often comes from the radiation oncologist, is how much of this flare do we include and target with radiation? Do we include it all? Do we include a little bit of it? Do we include none of it? And sometimes conventional ADC isn't really able to resolve this question. But he was looking into high B-value diffusion-weighted imaging. And why he was looking into that is because if we jump forward in time from this patient and look at the recurrence, this high B-value diffusion-weighted imaging seems to correlate nicely with our region of recurrence. And then if we look back in time, this high B-value, it gets about halfway through this aspect of the flare imaging. So maybe there's some signal there that, at least in this patient, we should have included about half the flare, right? So up to about this point when we target with radiation. And then he's looking at this in a larger cohort. And with that, there's a few next steps, especially on the clinical analysis side of things. So that trial that I showed, led by Jay Detsky, that's finished recruiting at about 109 patients. So they're looking right now at analyzing that and moving on to future versions of that trial. And eventually, to say summarize, jump to the bottom of the slide, eventually looking at how we want to give a radiation boost to these patients. Is it going to be ADC? Is it going to be with high B-value DWI? And of course, we love the MR here, but maybe it'll come from a different group that's exploring PET imaging, for example. And what the MR LINAC technology is especially good at is an adaptive boost. So we can monitor these changes in functional imaging and adapt our radiation to those changes. And with that, I'd like to thank the team here to make these advances possible. Liam and Rachel for the invitation to speak here today. Thank you for your attention, and I'm happy to try to take any questions.
Yeah, so thanks so much, James, for the great talk. So I will open the floor to questions. So for those on Zoom, you can just put it in the chat, or you can feel free to unmute yourself. But I think we have one in person from the back. So Greg, please feel free to take it away.
Very interesting. Thank you very much. So, on the